Welcome to the Hepatitis and HIV Virtual Education Summit Series presented by Johns Hopkins University School of Medicine at ID Care Live. My name is Dr. Amir Kasim. I'm Director of Clinical Policy at the American College of Physicians, and you're tuned into a live session called New HIV Screening Recommendations for Primary Care Providers. Joining me today is very distinguished speakers and expert in this field, Dr. Jeffrey Kirkner. Welcome, Dr. Kirkner.
Thank you, Amir.
Before we get started, I would like to remind you, our audience, that we will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. Dr. Kirkner is Medical Director of Comprehensive Care Medicine for HIV at Lancaster General Hospital in Lancaster, Pennsylvania. He has instituted free rapid HIV screening and testing programs at clinical sites in Lancaster and has worked with American Academy of HIV Medicine in Pennsylvania to remove written consent for HIV testing. As we all know, HIV screening is a very, very important issue. It's a serious healthcare problem for the United States as well as for the rest of the world. The prevalence rate for HIV in the US, according to CDC, is 1.1 million people, and their incidence rate is 50,000 folks every year. And that gives you a feel for that how important it is for us to think and start thinking about screening for HIV. And now I'll hand it off to Dr. Kirkner. Jeff.
Thank you, Amir. It's a pleasure to be here, and I'm really hoping, as a family medicine physician myself, I can encourage and emphasize many of the people in our audience today, many of our physician colleagues, of how important it is to routinely screen their patients for HIV disease. Our learning objectives today are as followed. We want to analyze the rationale for HIV screening recommendations, and I'll show you very specifically the clinical benefits of routine HIV screening as part of routine health care in your patient practices. So first, we'll look at some epidemiology. Obviously, HIV has been around for many years, and this slide from the CDC shows, going back to around 1985, how with the successes of antiretroviral therapy, patients are living much longer with HIV disease. If you look at the slide, we see around 1995, 1996, which was the onset of the highly antiretroviral therapy era, we had a significant decline in deaths due to AIDS. Consequently, our patients are living much longer, so we have more people carrying the virus in the United States. This next slide pretty much shows the same thing, again showing that patients are living much longer with an HIV diagnosis. I have patients in my own clinical practice who have now been HIV positive for over 25 years. Consequently, again, people are living longer, and there is a larger pool of individuals who can potentially continue to spread the virus. Here's an overview of the prevalence of HIV in the United States from around 2010. And you can see, as a practicing physician, regardless of where you live, there are patients with HIV disease and AIDS living in your individual states. Certainly, the lion's share of cases are focused in the East and West Coast and also the Southeast United States. High prevalence areas, of course, Maryland and the District of Columbia. But again, no state of the 50 is unaffected by this epidemic. And in terms of HIV prevalence, we obviously are very well aware that the majority of cases exist in sub-Saharan Africa, but this is a global pandemic. But very interestingly, if you look at this particular slide, you can see that HIV prevalence in certain cities in the United States, such as New York City, other areas, is actually higher or as high as the prevalence in many of the sub-Saharan African countries. Again, a surprising statistic for many individuals when they hear this, particularly my physician colleagues. So let's go on to some polling questions. Do you routinely offer opt-out HIV testing in your clinical settings? Yes or no?
So the results right now, Jeff, is showing around 80%, 70 to 80% are saying yes, but around 30% are saying no.
Okay, well, hopefully by the end of our talk today, Amir, we'll have some improvement in that number. Another polling question. So here's some clinical scenarios. The first one, this is a 64-year-old male. He's coming in, he's been a long-term patient of your practice. He's coming in for a 6-month routine checkup. He asks you for a refill on certain prescriptions, including sildenafil. So would you offer this individual an HIV test?
Okay, it's again 70% yes and around 30 or so percent no. And this is one of my favorite questions, I think. And towards the end, I'd really like to hear from the folks who are not offering routine HIV screening in this patient population.
And perhaps some of these patients, again, although this gentleman is asking us for sildenafil, obviously implicating he's sexually active, but again, I think that age bias that many of our colleagues have, that older individuals are not sexually active, and we certainly know with the epidemiology of HIV, this just is not true. Well, let's move on to a third question. So here's a 23-year-old single male. He presents for an annual physical. Upon his exam, he tells you he doesn't smoke, he's a social drinker, he doesn't use drugs, his exam is unremarkable. He does answer your questions about sexual history and says he is sexually active, although you don't specify whether with males or females or both. He does use condoms. So would you offer this young man an HIV screening test as part of his well visit today in your office?
So very good. It's 100% are saying they're going to offer.
Excellent. So I think, again, this question probably spurned our physician audience to say, well, this is a high-risk individual, but again, perhaps showing a little bit of their bias. So one more, and this is a very interesting one. So this is a 33-year-old female known to your practice. She comes in for her yearly well-woman physical, perhaps her pap smear. She's married. She has 2 children. The rest of her medical history is completely unremarkable. Would you offer her an HIV test?
So 60% will say are saying yes, and 40% are saying no.
I think the caveat with this scenario, when I saw this question earlier, Mir, would be, was she tested during her pregnancy? We're going to touch upon that later. So if indeed she was, she's monogamous, you know this patient very well, and she says, yes, I've had 2 pregnancies, perhaps you even did her prenatal care, and you tested her for HIV. Of these 4 clinical scenarios, this may be one situation where you're saying, yes, she's been screened for HIV, not once, but twice. She's negative. You would move on to risk-based screening. There's no specific risk here. So our audience who voted no, I would probably give them a little bit of credit for that answer in this scenario. The other 3 situations, all of those individuals should have HIV screening. So let's move on. So HIV screening recommendations. This is really the focus of our talk this afternoon. So when I talk about HIV screening, particularly to family physicians, we talk about it in the context of other screening tests. And way back in 1968, the World Health Organization put forth 4 very definitive criteria that justify routine screening in an otherwise healthy patient population. And these are as followed. It's a serious health disorder that can be detected before symptoms develop. The treatment is more beneficial when begun before symptoms develop. That we have reliable, inexpensive, and acceptable screening tests. And lastly, that the cost of screening is reasonable in relation to anticipated benefits. And when these 4 rules from the World Health Organization were applied to HIV screening by the CDC several years ago, they really fit in deference to many of the other screening tests that family physicians and other primary care physicians are asked to do in their clinical practice. With that in mind, in 2006, Dr. Branson and colleagues at the CDC issued this very well-known, at least to me personally, MMWR, calling for one-time routine HIV screening regardless of risk-based. And some of the specifics of the CDC's recommendations way back in 2006 were as followed. They recommended one-time opt-out screening for all people ages 13 to 64. Written consent, which historically has been a huge barrier to getting testing done in clinical practices, they felt was not necessary. And the same way with pre-test counseling. Again, pre-test counseling or post-test counseling, unfortunately, was never really shown to significantly impact patients' behavior. So again, the CDC worked very hard to say, if we're going to ask primary care physicians to test in their office, we need to remove some of these barriers to testing. And then what the CDC said, if you screened your patient population one time, they tested negative, then you could return to risk-based screening in your patient population and not continue to do this on a yearly basis. And obviously those patients who screen or test positive, then could be tied into clinical care. Thanks to Amir and his colleagues, in 2009, they followed the CDC's recommendation and very aggressively put out this specific statement by the American College of Physicians for their physicians, general internal medicine doctors, to again go on board with the CDC and to say we should be screening our patients one time. They encourage clinicians to adopt routine screening for HIV and encourage patients to be tested, really kind of a two-way street here. And then beyond that, just like the CDC said, that clinicians need to determine by asking good questions other patients, looking at risk-based screening on a yearly individual basis. But I think that the key point in retrospect, in 2006, we had the screening guidelines. In 2009, 3 years later, we only had one really major medical organization, that was your American College of Physicians, saying, yes, what the CDC says we should be doing. And unfortunately, there was a significant time lag for physicians and other medical organizations to really buy into these recommendations. Fortunately, fast forwarding ahead to November 2012, and then most recently in April of 2013, finally we have a multitude of different medical organizations really finally buying into the CDC recommendations, saying, yes, we should be doing one-time routine HIV screening in the United States. And the various groups that you can see here, I think the most significant was coming from the U.S. Preventive Services Task Force. They really did not buy into the original 2006 guidelines because they really felt that there was not enough good evidence to say that everybody should be routinely screened one time. Well, thankfully, with better studies showing that early treatment worked, the task force relooked at the evidence, and in April this past year, just a few months ago, issued Level A recommendations for routine screening for HIV in the United States. And this is quite significant because under the Affordable Care Act, any specific screening recommendations by the U.S. Preventive Services Task Force that receives a Level A recommendation will be covered by third-party payers, both private insurance and Medicaid and Medicare. And you can see, along with the USPSTF, there's many other organizations, the American Academy of HIV Medicine, the American Medical Association, the American College of OBGYN, my own organization, that being the American Academy of Family Physicians, also agrees that routine one-time HIV screening should be done with every individual in the United States in clinical practice. So looking at some of the outcomes, why are we doing this? And this is something we're hopefully going to emphasize strongly over the next 15 or 20 minutes, why this is critically important. So obviously we want to get patients screened, we want to determine who has an HIV diagnosis, and then beyond that, as with other chronic diseases, whether it's diabetes, whether it's malignancies, we really want to link these people to care. And the linkage to care with HIV is probably a little more important because obviously we have good treatments, we want to improve quality of life and survival, but we also want to prevent new infections. So really the whole idea of testing, identifying people and linking to care really has two goals, as we can see at the end right here. One of the other reasons, again, that the CDC has put forth these guidelines, and we buy into these strongly, is that still a significant number of people in the United States are unaware of their status. At one point, this was about 25%. We've done better, but again, we can see most recently, still about 1 in 5 or 18% of people in the U.S. are unaware of their status. And we feel that these individuals are probably accounting for more than half of those 50,000 new infections that you alluded to earlier that we're seeing, because consequently, if people don't know they're HIV positive, they're not necessarily going to change their behaviors because they're not thinking about spreading their virus to somebody else. On the other hand, Gary Marks and colleagues quite a few years ago published data to show that if patients found out they were HIV positive, indeed, they were significantly more likely to change sexual practices because they don't want to transmit their virus to others. So again, identifying more individuals who don't know they're HIV infected is one of the real goals of the CDC screening guidelines going forward. So why routine screening? Again, as I said earlier, risk-based screening just has not been effective. Again, many people don't necessarily know they've even put themselves at risk for HIV. They're not really sure of how you acquire the virus. And I'll show you further data, again, purporting and from my own clinical experience, that risk-based screening just misses too many individuals. Here's some more examples of that. Patients basically may not even disclose to me as their family physician or in a primary care setting, even though we think we know our patients very well. Many individuals, including in this particular study, 39% of men who had sex with men didn't disclose this status to their healthcare provider, and men who have sex with men, unfortunately, make up the largest number of new infections we're seeing yearly in the United States. The other individual piece of information is that patients who went to EDs, emergency departments, where they were offering rapid testing, at least 50% or more did not identify a traditional HIV risk factor when they were asked about this, and tested positive nonetheless, and were probably quite surprised to find out indeed that they were HIV positive. So let's look at the importance of screening, early diagnosis, and why treatment is so important, and actually why treatment has been so effective. So where were patients tested back in 2006? And I think this slide emphasizes the importance of the doctor-patient relationship and the fact that even though many patients haven't been tested or screened for HIV in the United States, as well as perhaps other chronic diseases, I think many physicians, if they have a trusting relationship with their primary care provider, this is still who they're really looking for as the expert to recommend, should I have something done medically or should I not? And you can see in this particular study, more than half of the patients who were tested in 2006, and I think this is a positive slide, were indeed tested in their primary care physician's office. Not to say that we shouldn't be offering HIV screening in a variety of other settings, whether it's public health settings, whether it's a pharmacy, whether it's at our free walk-in program. But at the end of the day, it appears that most patients would be rather tested for HIV at their primary care physician's office if indeed testing is offered in that setting, and that's really the goal going forward. That being said, I think this data is sort of the good news, bad news in terms of family physicians, primary care physicians recommending HIV screening for their patients. As you can see in this particular study from the Kaiser Family Foundation, at one point in time, only 17% of adults said a physician or healthcare worker actually even suggested an HIV test. And this was after the 2006 CDC guidelines. Of those never tested, 27% said that physicians never recommended testing. And interestingly, sort of flipping it around, 26% of patients said they were specifically tested because their doctor recommended it. And a real perplexing, perhaps, piece of information, and again, I think this goes back to good doctor-patient communication, 25% of patients in this Kaiser Family Foundation poll thought they were tested for HIV as part of the routine exam when indeed they weren't tested for HIV. So a lot of sort of mixed messages, but interesting data here. But I think at the end of the day, this really has to be something that primary care physicians in the clinical setting have to be offering and recommending to the patients that they see. So in 2006, here's a polling question, Amir. What percentage of those persons who reported being tested for HIV in the preceding 12 months reported being tested in a private doctor health maintenance organization setting?
So I would say 17% are falling, and they're all evenly distributed, generally speaking, if you look at them.
Okay. Well, the correct answer here is 53%. I'm sorry, 17%. 53% was a number earlier on the slide where patients said they prefer to be tested in their family physician's office, but 17% exactly, a very, unfortunately, low number at that time, and I think a number that slowly is improving.
And do we know in that slide, was it high-risk population or was it everyone when they said that the 17% are getting tested or physicians are asking the questions? Do we
I think
know
that was everyone. I don't think they were breaking that out into high risk, low risk. Basically, it was just 17% of a total number. Again, not very good when we want this number to be close to 100% going forward. So let's move ahead, and this is a slide that's probably worth showing just because of the success of screening for HIV in pregnancy. So way back in 1994, ACTG 076 was a very pivotal study published in the New England Journal of Medicine showing by screening pregnant women for HIV and treating those who were positive with AZT during pregnancy, intrapartum, and then giving the infant 6 weeks of AZT after birth, dramatically decreased, a 95% decrease in the rate of perinatal HIV infections. And you can see going forward then, as a result of that, routine screening of all pregnant women was recommended, and you can see the dramatic decline in newborn infections, which is now down to maybe somewhere about 100 a year, which is really considered a sentinel event. Where we do prenatal care in my clinical practice, we've had no newborn infections for the last 15 years because we screen all of our women and treat them who are HIV positive. So it would be wonderful to see a comparable slide in our other patient populations. But again, I think it's emphasizing the point that doing this correctly and treating those individuals who are infected dramatically decreases new infections, at least in this patient population. Another reason that we are wanting to identify and treat patients for HIVs these days is some of the information that's coming over the last 5 to 10 years, looking at patients living longer with HIV and finding, unfortunately, in many situations, even those treated, but particularly those untreated, seem to be at higher risk for other comorbidities. We always think about age-defining malignancies and opportunistic infections, but indeed, looking at HIV as a pro-inflammatory condition, I think many of us are somewhat surprised that we're seeing a higher incidence of heart disease, cardiovascular disease in our HIV populations, liver disease. Many HIV-infected patients are co-infected with hepatitis C, and we've learned that those two viruses together, if you treat the HIV, the patients with chronic hepatitis B and C will do better. Kidney disease, we've known for many years about HIV-associated nephropathy, and we're seeing a growing number of non-AIDS-related malignancies, so there seems to be something about HIV positivity that also lends to patients having a higher risk for developing malignancies. So looking at these collective diseases, again, a strong reason as to why we should be treating all patients with HIV infection. Looking at some of the cardiovascular disease, and this has been a personal area of interest of mine over the last 5 to 10 years. This is a study by Ken Lichtenstein looking at the HOPS cohort, which has been followed for many years in the United States. And very interestingly, Ken published this paper in Clinical Infectious Diseases a few years ago and actually found that having a low CD4 count was a significant risk factor for having a cardiovascular event. I think this was very surprising to many people in the field. Again, looking at the fact that HIV in itself as a pro-inflammatory condition seems to be turning on a lot of other illnesses that patients can be at risk for without antiretroviral treatment. And here's another slide from Ken's study, essentially showing that if you had a CD4 count less than 500, and again, these were the men in the HOPS cohort, that you had a 25% increased risk of a cardiovascular event, which actually was greater than having diabetes, which is very interesting to me when I saw this data because we often look at diabetes as a cardiovascular risk equivalent, and having HIV with a low CD4 count or CD4 count less than 500, at least in this cohort, significantly was more important than having diabetes as well as having a high cholesterol level. So again, showing that HIV in itself, along with historically infectious-related diseases, seems to put patients at risk for a lot of other problems as well. Looking at another aspect of why we treat patients moving away from comorbidities like heart disease, liver disease, renal disease, this was a very critical and very interesting paper published from some colleagues in San Francisco looking at something called community viral load. And this is basically assessing the patient population in San Francisco, as you can see, starting in 2004 and moving ahead to 2008, we were aggressively treating more individuals as we had been with HIV and looking at sort of a community viral load for the city of San Francisco. And you can see how effective treating more patients with antiretroviral therapy was in terms of new infections from 2004 to 2008, quite striking, about a 50% decline in new infections, basically because we feel that patients on antiretroviral therapy are with suppressed viral loads are much less likely to transmit their virus to other individuals. So this, again, is something I think has been mirrored in other major cities around the United States, saying, again, that we know that treatment not only works to keep people well, but this is sort of the concept of treatment of prevention that more and more of us are buying into. And again, another key reason why we want to get people screened, identified, tested, and into care to prevent new infections. And this is a good example of how this can work if done properly and done effectively. And this is another study. This is really probably one of the pivotal studies, Amir, in the I would say, in the history of HIV treatment and prevention by Cohen and colleagues, published in the New England Journal about a year and a half ago. And this was the HPTN 052 trial that really showed dramatically for the first time that treating individuals with HIV infection dramatically decreased and almost prevented transmission. As you can see in this particular study, being on antiretroviral therapy basically produced a 96% reduction in HIV transmission in these discordant heterosexual couples. Most of these individuals lived in Africa, but some of these patients were in the United States and South America. But this study itself, I think, really is a crucial study and will probably go down in the history of HIV literature as a pivotal study in terms of treatment as prevention. And again, one of the reasons why we're really emphasizing that all of our patients who are HIV positive, regardless of their CD4 count, regardless of their viral load, really get into treatment and to get on antiretroviral therapy. Again, to mirror exactly what was seen in the 052 clinical study, that treatment as prevention truly works, is truly effective, and it truly is a goal that we should have for all of our patients in clinical care. So late diagnosis, this is a real personal pet peeve of mine. And again, keeping in mind here that we're looking at, again, the reasons why the CDC and now the U.S. Preventive Services Task Force and other groups are saying that we need to be screening patients for HIV because we continue to see late diagnosis. Late diagnosis of HIV infections is common among persons with newly diagnosed HIV going back to 2008. 33% developed AIDS within a year of diagnosis, which means they were probably HIV infected for at least 10 years. During this period, many of these patients missed opportunities for getting screened, getting treatment. Not to say that these patients can't get into treatment and do well, because we've all treated patients with low CD4 counts, and we've done a pretty good job at getting them as well. But if you look back, and I'll cite a quick example of a patient I saw in my clinical practice in the last couple of months diagnosed with cryptococcal meningitis, a CD4 count of 9. We look back, he had about 15 encounters with his primary care physician practice, with a couple of specialty physicians' practices over the last 2 years, as he was having a multitude of clinical symptoms, weight loss, rashes, low white blood cell count, until he finally presented with a serious life-threatening opportunistic infection, which led to his AIDS diagnosis. So again, I think all of us who work in this field can cite clinical anecdotes of patients presenting late to care, getting diagnosed when they have very low CD4 counts, and then retrospectively looking back and seeing how many times they've encountered physicians, emergency rooms, subspecialists, and were not screened or tested at that point for HIV, even when they had clinical indicators to say something's going on here. What is it? It's not malignancy. It's not a connective tissue disease. These patients have HIV, but it wasn't diagnosed. In terms of effectiveness of treatment, again, why we want to diagnose patients earlier, as I said, we can get patients with CD4 counts 50 to 100 quite well, although clinically they don't do quite as well. But I think this slide is pretty striking because obviously we hear about the war on cancer. We've done an incredible job in the United States preventing and treating cardiovascular disease. But if you look at some of these other illnesses relative to the survival with antiretroviral therapy, I think it's pretty striking if you look to the right and see how effective antiretroviral therapy is relative to chemotherapy for lung cancer, chemotherapy for Hodgkin's disease, cardiovascular disease. It far surpasses those other chronic illnesses in terms of the effectiveness of therapies that we have and how well our combination therapies have worked through the years to treat patients with HIV disease. Not certainly be dismissive of the wonderful gains we've made in cancer treatments and cardiovascular disease, but I think this is, for many of us and hopefully for our patients, a very dramatic slide to look at. So that being said, I think the Department of Health and Human Services really took a step in the right direction in about 2011, looking at many of the issues surrounding antiretroviral therapy, including some of the comorbidities that I talked about earlier, but also noticing that by treating patients with HIV, we can prevent new infections. So the most current recommendations are that anybody with HIV infection should essentially be treated. As you can see, the strength of the recommendations changes depending on the patient's CD4 count at diagnosis. And if you go below 350, we have strong randomized controlled trials to say that HIV treatment is really the way to go, but 300 to 500, we have very good observational studies, and even above 500, HIV treatment is recommended, though admittedly it's based on expert opinion. But that being said, the approach that I take with my patients these days, residents in our clinical setting, I say any new patient with HIV disease, we really have to look for a reason not to treat them, regardless of their CD4 count, for many of the reasons that we've cited earlier, not only prevention, many of the comorbidities, and we know for a fact that treatment at any point in the disease, but sooner as opposed to later, truly will extend people's lives. And that's really our goal in medicine, is to help our patients live longer and live healthier lives. So really these days, almost anyone with HIV, again, we have to sort of look hard for reasons not to treat perhaps active addiction, mental health issues that we can work through, and then when those issues are taken care of, we want to get our patients on antiretroviral therapy sooner as opposed to later. And that being said, here is just a small sort of take-home study, again, looking at the probability of survival, or turning it around, the probability of death, based on CD4 count when you go into therapy. So you can see over a 5-year period of time, if your CD4 count is only 0 to 24, your likelihood of dying is much, much greater than moving down to the red bar at the bottom, where if your CD4 count is greater than 350, your likelihood of death or your likelihood of living with antiretroviral therapy is much, much greater. And we have many other studies and lots of data, again, to support early initiation of antiretroviral therapy, to improve survival, to decrease comorbidities, and to help people live longer and healthier lives. So let's move on to another discussion question. So which of the following statements is false? 1/3 of people with HIV are diagnosed with AIDS within a year of their HIV diagnosis. Most people will become aware of their HIV diagnosis, which will significantly reduce their high-risk behaviors. Unrecognized and untreated HIV can contribute to cardiovascular, renal, and non-AIDS associated cancers. Or the fourth statement, the average CD4 count at the time of HIV diagnosis in the US is currently 635.
So the answer is, majority are saying the average CD4 count at time of HIV diagnosis is 635.
Well, that is correct. That is the false statement. I was forgetting the spin on this question, but I'm glad they got that one right. Yeah, I think the average CD4 count at time of diagnosis is considerably lower than that. I think at one point, I know several years ago at the retrovirus meeting, I think we were under 200, which again sort of was flying in the face of saying, why shouldn't we be screening everybody, because we're just not doing a very good job. Even with risk-based screening, we're still picking up a majority of patients who already have an AIDS diagnosis. I think that number is a little bit better. I've seen data from different cohorts around the country, and I think the number is in the 300 to 400 range, but still, again, we have some ways to go there in terms of detecting HIV early as opposed to later, but certainly not at 635. So another question, what is responsible for the decline in perinatally acquired AIDS? Widespread HIV screening of all pregnant women, antiretroviral therapy use during the antenatal, perinatal, and newborn periods, or an overall reduction in cases of HIV, or 1 and 2?
So majority are picking the widespread HIV screening and antiretroviral therapy, ART therapy in antenatal and perinatal newborn periods.
Excellent. That's good to hear. And I think that was one of the, we showed one slide on this, of course, and I think that emphasized that point very, very strongly. And I think the key point with perinatally acquired HIV and HIV screening is something that I still see in our clinical practices, and that's many of our private practice OBGYNs and probably some of my family medicine colleagues, again, depending on where they practice, often are not screening their pregnant women for HIV, even though this has been a universal or at least a national recommendation for close to 20 years. So I think one of the key points I would say today, although most of our audience got this question correctly, if you are an OBGYN or your primary care physician or primary care provider who does prenatal care, please screen all your women at intake to pregnancy for HIV. This is essential and crucial. And for the most part, this is being done. But again, I still think there's missed opportunities for screening. Of course, any perinatal infection that we would see, any newborn infection in the United States would probably be one example of that. So another question, which of the following conditions may be affected by uncontrolled HIV replication? Cardiovascular disease, diabetes, arthritis, or obesity?
Cardiovascular.
100%?
Mm-hmm.
Okay, excellent. Yeah, so again, cardiovascular disease, as I showed you earlier, there truly is a strong association between HIV infection, specifically HIV infection, untreated HIV infection, and premature heart disease. I think some of the pathophysiology, some of the biomarkers, some of the other issues surrounding that association, we're still working on, still trying to figure out. Unfortunately, smoking continues to be a big issue in patients living with HIV, and in many of the studies looking at cardiovascular disease, cigarette smoking seems to be a co-founder. But again, those of us in the primary care setting or in the infectious disease setting, if you're caring for HIV patients, you're caring for smokers. So I think we all have to play a role in smoking cessation and hopefully work towards diminishing the risk of cardiovascular disease in our patient population. So another question, in 2007, approximately how many HIV positive patients in the US were late testers or diagnosed with AIDS within a year of receiving HIV diagnosis? And we'll see the answers there below.
So majority are going in the direction of 33%.
Very good. So again, they were listening to our discussion. So about 1 in 3, and again, this is the point being we need to do better than this. I mean, certainly we're still going to have patients turning up in our ERs and our clinical practices with late presentation to illness. But again, if we really are getting people appropriately screened in our private practice settings and our clinical settings, this number should drop significantly, I hope, over the next couple of years, and we'll see fewer and fewer patients preventing late to care with age-defining malignancies and certainly with opportunistic infections. So I think we have a time to maybe work through this case.
Definitely.
We do? Okay, so this is a case study we'll go through for our audience, and I think we'll find this somewhat interesting, and hopefully we'll have some teaching points with this case as well. So this is a 51-year-old African-American female. She was recently engaged, and she goes to the American Red Cross to donate blood. And of course, we know when you donate blood, you're screened for HIV, hepatitis C, hepatitis B. And I've had a few patients into our clinical practice actually who surprisingly found out they were HIV positive when they went to donate blood. So she receives the call from the Red Cross and was told she was HIV positive and she should go to her doctor. She and her fiance presented for rapid HIV testing. So here are her baseline laboratory studies, and these are fairly routinely done. We do these for all patients presenting newly to care. So her CD4 count, interestingly, sort of in keeping with that earlier question, was on the high side, 716. So basically a normal CD4 count. So our assumption would be this was a situation where she was actually picked up quite early, but she really wasn't being routinely screened per se. She was screened, of course, because she was donating blood. Her viral load was somewhat low, and again, not surprising, women often have lower viral loads than men. And then the other screening tests that she underwent, all quite appropriate: TB screening, screening for hepatitis C, screening for hepatitis B, syphilis screening, all these came back negative or non-reactive. So for the most part, except for the HIV diagnosis, this woman would look pretty healthy. On the other hand, this is her fiance, her presumed sexual partner, and he went with her, as we said with this case, to have rapid testing, and he was found to be positive. With rapid testing, which I don't think we touched on earlier, which has become a very effective way to roll out screening, as good as the rapid tests are, the CDC does recommend that all rapid tests always be confirmed with serologic testing. That's still standard of care. So this individual, I'm assuming, had serologic testing after found to be HIV positive. but unlike his fiance's numbers, his don't look so good. So his CD4 count is 147. So he already has, by CDC case definition, an AIDS diagnosis. He has a fairly high viral load. Viral loads over 100,000 are often a break point for using certain regimens. So he's fairly viremic. And we also know, as I said earlier, the degree of viremia correlates with infection. So this is an individual situation where we have to make the assumption that WG unfortunately infected his fiance. He's also positive for hepatitis C. Hepatitis C is rarely sexually transmitted, although it can be, but looking back, fortunately, she tested negative for hepatitis C. And then his other screening tests, as we can see, for hepatitis B, hepatitis A, and syphilis were all negative. So I think without going on to this specific, I'm going to go back just to discuss this case a little bit more. I've seen this clinical scenario in my practice probably at least a half a dozen times over the last 5 years, where we have somebody come into our rapid testing program, they're positive. Sometimes they're surprised or upset. We do the confirmatory test. In almost all cases, we have a very low false positive rate. So then immediately the next question is, who is your sexual partner? And they have to come in and get tested. And more often than not, it's a new partner, somebody they've been with a year. I've had a couple situations where the partner brought in has been identified as a fiance, and I sadly say now instead of one patient, I have two patients. Mm-hmm. And again, this would be a scenario where I've counseled individuals and younger patients as well, saying in this day and age, if you are going to be sexually active with somebody, regardless of your age, it really makes sense to get HIV screening. So whether you're 20, 30, 40, in this case, this couple was in their 50s, to go and get tested. It would be really interesting to go back and look with WG, for instance, saying how many clinical encounters did he have with his primary care physician, which hopefully he has one, or in an ER setting, which were missed opportunities for testing. So as we said, with the CD4 count of 147, he probably has been HIV positive for 5 to 10 years, perhaps even longer. He's passed his virus on to his partner, who, interestingly, had she not been a blood donor, maybe not have even gotten tested, and may have gone much longer. He may have gone much longer. So you could argue in some ways what was fortuitous that she decided to donate blood, she tests positive for HIV, and then sort of working back through, he being her partner, he tests positive as well. So again, this scenario has played out in my clinical practice quite a few times, and for the most part, if we can get early routine screening in primary care settings, I think this should happen much less commonly than we've seen it happen. And I think we have a closeout question here. So what are the benefits of universal screening for HIV? And hopefully if I did my job today and you did your job today, and consequently our audience will be able to answer this specific question quite well. So what are the benefits of universal screening for HIV?
So 90% are getting all of the above.
Okay, well, that's pretty good. I would have liked to have 100%, but I think perhaps...
and it's changed to 100%.
Well, I suppose maybe the one thing we didn't get on too much was the cost-effective strategy. And certainly when the CDC put out their recommendations in 2006, there was some discussion about, is this a cost-effective intervention relative to other things that we screen for? And there were several very good studies done to show that one-time HIV screening was as cost-effective as things such as mammography. Again, not everybody bought into that. Not everybody is aware of that. And I would even probably argue that many primary care physicians might not be fully aware of cost-effective screening strategies for many of the things that we do and look at the cost long-term and upfront. But that being said, I think hopefully they got the emphasis today that early diagnosis is important, that decreased transmission by getting people diagnosed early and on treatment is very important, as we saw from the 052 study. And needless to say, patients are living much longer with HIV, particularly those who are diagnosed and treated earlier. We actually tell many of those patients they can have a normal life expectancy if they maintain themselves in care and stay on antiretroviral therapy.
Mm-hmm. Well, Jeff, you presented very convincing evidence, and I think it does point in the direction that we need to adopt routine screening in our daily practice. And there are a few questions that I'd like coming from the audience that I'd like you to answer. And I think some of them are very important that we are dealing with every day in our practices. So one is regarding, so once a diagnosis has been made, when do you start the treatment? Do you start that very day? Do you wait for a week? What are the current recommendations? When do you start the treatment?
Well, once the diagnosis is made, usually with routine screening, you're not going to have those baseline studies that we looked at earlier. So you really want to have a baseline CD4 count and viral load. Now, that being said, earlier I showed you that the Department of Health and Human Services guidelines say that everybody with HIV infection should be treated, but you really want to have that baseline CD4 count and viral load. Starting antiviral therapy is rarely an emergency, I would say, unless somebody maybe has a CD4 count under 50 or they're, again, clinically symptomatic. But we're talking about routine screening. These patients generally should look healthy to us. So basically, we want to get their baseline studies done and then bring them back 2 weeks, 4 weeks. Again, there's not really an emergency here. I rarely would ever start treatment at the first visit. We want to make sure patients are appropriately counseled, that their patients have been tested, that they have access to medications. The drugs are expensive, so sometimes getting ADAP programs in place, insurance coverage in place is very important. But usually within a month or 2 or 3, sometimes patients aren't psychologically ready to start treatment, that we're telling them you're going to be on these medications for the rest of your life. That can be really challenging. So again, unless they're showing clinical signs or symptoms of HIV infection, we usually wait, and sometimes we'll go 2 months, 3 months, 4 months. I mean, you don't want to lose those patients. Keeping them in care is very important. And again, by treating earlier, I think that allows patients to maintain in care and buy into that this is important. I need to come for my doctor visits. But I really think you want to have that baseline information in terms of their disease status. You want to make sure they have coverage for their medications, and that they really buy into the care, that they believe that your treatments that offer them are really the right thing to do, which we know that they are, but patient education is important, and that can be done over a period of several months.
And just a follow-up question again from audience. There's this asymptomatic patient population.
Yes.
They're less likely to be convinced that they should start taking medications, and you mentioned that you can start counseling, you can do that.
Right.
What if these resources are not available for you? Let's say if you're practicing somewhere where some of the counseling services may not be available, and how do you do this? First, the asymptomatic population, how do you convince them, and if you don't have the services available for support group?
Well, I think the asymptomatic population gets back to the whole idea of medical screening for any disease. I mean, screening by virtue means we're taking somebody who's asymptomatic and we're screening for colon cancer, we're screening for breast cancer, we're screening for HIV in a patient who otherwise would appear to be healthy. So we're taking asymptomatic patients and we're screening for diseases that we know by diagnosing and treating early and appropriately, we're going to decrease morbidity and mortality. I think HIV is unique in that along with decreasing morbidity and mortality, that we also have the whole prevention piece, because things like diabetes, things like hyperlipidemia, cancers are not transmissible to other individuals. So I think that's the unique aspect of HIV infection that we really need to keep in mind. So again, I think having the resources, obviously, for patients with any chronic disease is very important. Hopefully with the rollout of the Affordable Care Act, more patients will have access to medical care, particularly in a primary care setting. And again, this gets back to, I think, our point today. Again, asking primary care physicians, family doctors, pediatricians, internists, nurse practitioners, PAs, who are on the front line, and being a family physician myself, there's a lot that we're asked to do, but I think the CDC recommendations, U.S. Preventive Services Task Force, have made it easier to screen in those specific settings, and then trying to find the ways to get patients the care that they need, which sometimes can be easier said than done, but there are resources out there, such as ours, which is a primary care HIV clinical site, and many others as well. But I think sometimes it might take a little bit of work by the primary care physician, if they are screening patients, to understand the baseline test, and then sort of saying, well, what do I do next? Make sure that they become aware of what are the resources in their specific community, particularly if they're not in a large urban center, to help their patients get the care that they need. And I would say that the resources out there, but it might take a little more work on your part to avail yourself to those.
And for the medical personnel that you just brought up, the issue that we're dealing with, some of us are dealing with more HIV patients or blood products and all. Are there any protocols or standardized recommendations in place? Well, how do you screen this population in terms of the physicians or other healthcare professionals? Do they need to be screened for HIV as well, more frequently, less frequently?
There's no specific screening guidelines that I'm aware that the CDC or any other medical group has put out for those of us as physicians that we should be screened more. I think if you're a practicing physician in the United States and you meet the U.S. Preventive Services Task Force or CDC demographics and you've never been screened for HIV, I certainly have myself, then you should be tested at least one time. But really, we wouldn't look at that population any differently, healthcare providers, non-healthcare providers, again, for HIV screening purposes. Certainly, exposure purposes, that's a whole different situation. A surgical injury, a needle stick injury, those kind of things all would precipitate repeat HIV testing. But if we're just talking about HIV screening, really there wouldn't be any different screening recommendations whether you were a doctor, a nurse, a physical therapist, an OR tech, apart from the regular population. All healthcare workers should be screened for HIV at least one time, would be my recommendation.
And of course, I'm getting some very, very good questions from the audience, and we're always running short of time. One question that I just wanted to ask you is, you presented a very convincing evidence when it comes to screening. I don't think anyone can argue that we shouldn't be screening. There are benefits of early screening and all that. So why is the uptake so slow? Why is it not happening? And it's a hard question to answer in 1 minute or so. But what do you think are the major barriers?
I think that's a great question. I think the major barriers now with physicians. I think there's still a don't ask, don't tell. I think there's still a fear of physicians to bring the question about HIV up with their patients because of patients feeling that you're perhaps being judged from a lifestyle perspective. And I think that's why we need to continue to normalize and destigmatize HIV screening and saying this is something we're doing for everybody. We're not singling you out because we think you're somebody who has different high-risk behaviors. We really want to get away from risk-based screening. Those individuals do need to be tested on a yearly basis. But I think the fear is, and with some physicians as well, is they are maybe not sure what to do with the results. And when I lecture to family physicians or other physicians as well, I think there's a basic knowledge base about HIV that you have a responsibility as a practicing physician to know, and that's the baseline evaluation after screening, just like you do a blood sugar and say, okay, now what do I do with that? Well, most of us know how to treat uncomplicated diabetes or know what test to do, and then get help from a consultant if you need it. So I think physicians are just thinking either they don't want to deal with the disease, is my impression, or I think more commonly they perceive their patient population to be not at risk. And we want to get away from that and saying, okay, maybe your patient population is not at risk, but screen your practice for a year, screen the patients you take care of, and see where we are.
Great. Thank you so much, Jeff. I think this presentation was really great. I learned a lot myself. There's always like few slides that I see, new data that I see that is always very convincing. I would like to thank Gilead Sciences, Boehringer Ingelheim Pharmaceuticals, and Vertex Pharmaceuticals for their support of this important educational series, in addition to educational support provided by Centers for Disease Control and Prevention. Please remember to complete the quiz at the end of the session to secure your CME credit, and stay tuned for the next session, Managing Hepatitis C Virus in Patients with Advanced Liver Disease, with Dr. Robert Browns and Dr. John Reines. My name is Dr. Amir Kasim. Thank you so much for joining us.